Welcome, everyone. I'm so thrilled to be here today to welcome you all. And I would like to thank Let's Move Pittsburgh, FIPS, for having us here, and for the Pennsylvania chapter of the ACC for allowing this event to happen. I think it's a timely event because this is 2018. It's an exciting time to be here in Pittsburgh as a cardiologist. My mentor, Lisa Villanueva, just won the Pulse of Pittsburgh Award from the American Heart Association. After 29 years, this award has been ongoing. She's the first female to win it, and I'm so very proud of her and very grateful to Lisa, whose mother's 90th birthday it is today. She made it in spite of that, so thank you so much. And to our newly elected governor of Pennsylvania, Katie Berlacher, who I'm so honored and happy to be working with. She is also the first female that is going to be the governor of the ACC Western part. So kudos to you, Katie, for leading your fellowship at Pitt and educating all of us. I'd like to start off by just talking about the guidelines on exercise. So exercise is advocated worldwide for the prevention of cardiovascular disease. The WHO wrote guidelines in 2008, which they will be updating this year in 2018. And these were modified and expanded by the ACC and the American Heart Association in 2013. So these current guidelines are primarily based on studies that show self-reported physical activity. And the current guidelines recommend 150 minutes per week of some type of aerobic exercise, along with 2 days of doing some kind of muscle strengthening exercise as well. The different studies that have informed these guidelines use questionnaires for the most part in assessing the physical activity. And these studies use either the amount of energy expended, intensity of activities, duration, frequency of the physical activity, and where it happened. Was it during your occupational time, or was it during time at home, domestic, during transportation, or was it just a leisurely event? And because these are all self-reported, there is some misclassification and some recall bias, misclassification because you're just reporting on a survey what you can remember, and recall bias because we're all forgetful. How can you even recall what you did, a week ago or, an hour ago in terms of your exercise? So, and in addition, these questionnaires that were used were largely based on data that was informing the male questionnaires. And so they were heavily focused on sports and not really asking about energy expenditures in the house, where a lot of women get their work done. And despite this, the studies show about a 20 to 30% reduction in cardiovascular risk reduction with physical activity. And even meta-analyses show about a twofold decrease if you look at those people who exercise for a living, say the postman versus a secretary who sits for work. So when I say exercise to my patients here in Pittsburgh, this is what they hear: exercise. Eggs are sides. Bacon. And they leave my office thinking, oh yeah, she's talking bacon, that Ritu. So I wanted to take a moment here to look and talk about, there's various risk factors for coronary and cardiovascular disease. And there are emerging risk factors that are pertaining to women. But in particular, I want to emphasize the two dots that I have outlined here: obesity and then inactivity. Obesity is a separate risk factor than physical inactivity. The studies show that they're independent risk factors of equal magnitude, and they do not cancel each other out. And although obesity is a risk factor for CVD, women more often get sidetracked into being told and focusing on weight rather than their male colleagues. And this came out in a study called the Virgo study, V standing for variation, R for recovery, and G for gender, and O for outcomes. And that showed, in addition to patient surveys that were done by the same researchers, that in fact, physicians more often harped on a woman's weight than any other risk factor. And in this study alone, women were more often diabetic, but despite being diabetic and that being a coronary artery disease equivalent, they were less likely to be on a statin. And their male colleagues in the study were more often overweight, but the women were the ones that were being harped on to lose weight. And in fact, 3/4 of these women actually had another risk factor, blood pressure that was elevated, diabetes mellitus, but they were not told. Only 16% were actually told that there was something wrong in terms of having a coronary artery disease risk factor. But double them, 34% were told, you need to lose weight. So obesity has a misogynist tone, and there was a very nice article written by Dr. Mertz about this very issue. Because what is happening is that women are being told, okay, it's okay, you're all right, just lose weight. And when they're told lose weight, they don't come back to see the doctor because they're waiting to lose weight. They're embarrassed, they don't want to come in, there's a social stigma attached to it. So this is a real, it becomes an issue. And body weight is actually not on any risk calculator. This is from the ACC. There are all other things that are involved, but not weight. And when we look at mortality data, indeed it has fallen. Of course, this is the latest from circulation, and you can see that there's a slight upward trend from the last two dots, 2014 to 2015. This is going to be published in March, but it's available online. And despite the fact that BMI has steadily been rising, the mortality in general has diminished. And obesity is also a little bit showing gender issues. So male pattern obesity, as you can see from this slide here, this is from the Economist cover from 2003. Some of you might have remembered this. Male pattern obesity is the visceral obesity that we see and associate with. You can see this man with a large soda sipping has got that risk factor. And women's obesity pattern is not a risk factor. That's in the hips and in the thighs. Central obesity that's measured by waist girth or hip ratio to waist is a marker for visceral obesity, which co-varies with insulin resistance and both in men and women. But from an evolutionary point of view, interestingly, men need this visceral source of energy because it is readily mobilized. It's where there's a direct source of gluconeogenesis from the liver in times of stress. And actually this stress response is actually greater in fat cells cultured from men than women, whether women are post or premenopausal, interestingly. So abdominal obesity is a greater risk factor than BMI, indicating that we need to measure waist to hip ratio, and that should replace BMI as an indicator for obesity. And despite that, there is a complete dose response curve when we look at exercise. So the greater physical exercise, the lower rate of cardiovascular disease. And this is linear, even though this actually is from the Women's Health Study, and this shows that women reported less physical activity on their questionnaires. And so it might even be a little bit lower. And you can see, I don't know how clearly it reads, but there's 200 kilocalories per week all the way going to 1,500 kilocalories. So there's a big range. And even the newer studies that are coming out, they're using a metabolic equivalent, such as the PURE study that was published just this past fall, which was a study of 170,000 people in 17 different countries. And they use metabolic units, which are really just the roughly equivalent of the energy that you need to sit quietly. And a 4-MET activity expands 4 times the energy that you need, that the body needs at rest. And despite using METs, we still see a decrease in mortality data that is the same dose response curve that we've seen earlier. I don't know, is this playing as a GIF? Okay, so this is a fascinating app. I don't know if any of you have seen it. It's called the SAGE Project. It's an app that actually is a food technology app that helps consumer navigate nutrition using these food characters. You can see this chocolate bar jumping rope. You can also see a pear doing yoga, a watermelon riding a bike, just to make things a little bit more fun for your patients and for yourself. Now, as a writer, I'm always concerned about how do you frame the question? What's the narrative look like? And we can think of exercise, or we can think of physical inactivity. And while we can think of them as 2 sides of a coin, they're actually, it hasn't worked when we look at just exercise, because that benefit message is not getting out there. And in the past, when we wanted to control smoking, we didn't just say, oh, well, if there are benefits of not smoking. So it's really how do we frame it? And as you can see here, worldwide, the cost of deaths from physical inactivity is greater than the cost from smoking. And that's still surprising. Physical inactivity is the largest risk factor that we have in this country. 1/3 of our women are not physically active, and it's the most prevalent risk factor. 1/4 of the women do not actually exercise, and 3/4 do less than what is actually recommended. And actually, when you look at the impact, or how physical activity actually impacts mortality, some of it is explained through intermediaries. So blood pressure reduction, 25% activity goes through blood pressure reduction, and about 20% also goes through dyslipidemia. So if you exercise, those are the things. But there are other things that are happening at the same time. There was a nurses' health study which actually looked at obesity and preventing, and diabetes. And there was actually a graded response when they found, when you start comparing normal weight women who are active, and then you start by taking those that are inactive but normal weight, their risk of diabetes goes up 1.5 times. And if you take active but obese women, their relative risk goes up to 2.5. And if you take inactive and obese women, their relative risk went up to 3.5 times. So there is a definite gradation. So if you're trying to prevent diabetes, the data is more consistent that being obese is a greater liability, greater risk for developing diabetes than just physical inactivity. But if you get diabetes, then physical inactivity is going to be an independent predictor of your mortality. For the interest of time, I'm just going to skip to 2018, since that's where we're in. And this is a beautiful study done by Dr. Lee, and she sent me this photograph that I am using of an accelerometer that she used in this study. She used the women's health study cohort, which was more than 20,000 women that were studied from the year of 2011 to 2015. And she put accelerometers on about 17,000. She got data for about 16.5. And what she found was this graded response based on the accelerometer counts per minute. And it was, again, a dose response. But interestingly, she saw an even greater effect. It was a magnitude larger than what we had seen with just physical activity questionnaires. And there's another accelerometer a study that's not published yet, but it was just mentioned in older women. And most of these older women up to the age 60s through 90s, most of them were doing just regular activities around the house, washing windows, using the sweeper. And some of them were also biking and walking outside briskly. And they also had, again, a dose response, diminished risk for cardiovascular disease. So moving forward, has anyone heard of Sweatcoin? It sort of comes from the idea of Bitcoin. So it's a #1 downloaded app. And this is a London-based company that says physical movement has economic value. So everyone's looking to make a buck. And this is a for-profit company, but actually you can download the app for free. I thought it was interesting. I don't know if any of your patients or you yourselves have seen this, but it's a wave of the future, certainly. And another study that took place with the Framingham Heart cohort is using behavioral economics and game theory and applying it to getting people to move. This study just looked at 200 people, 92 families, and divided them into gamification, which is supposed to make things fun. And it did. In fact, when they divided the cohort, what they said was, we're going to give you points to start the game, and you have to, you're going to lose those if you don't walk the set amount of steps. And so they applied this theory of principle of loss aversion to get them to move. And in the 12 weeks that they were enrolled in this trial, you could see that the ones using gamification were actually taking more steps. And it continued, although to a lesser degree, when they weren't followed up with text messages and emails to say, good job, or, keep it up. But gamification will be another way that we're going to blur the borders between what we need to do from a public health point of view and policy point of view, and allowing patients to have fun. I think it's something that we all have to consider, given that our kids, everyone who has kids here knows they're all addicted to their games, and it's hard to get them off of that. And I wanted to just thank Dr. Mertz, who loaned me this slide, which is really a reminder of why I started this Women in Cardiology, which really gets to the heart of the issue, which is funding. So if you look at NIH dollars, this is the last data that's available from 2015. What is spent on women's health is a fraction of what is spent on money from the Cancer Institute, although cardiovascular mortality is the #1 cause of death of women. And this is why it's very important that we're together tonight, because it's really about raising awareness that these numbers, along with other numbers like your blood pressure or cholesterol values, for yourself and for your patients. And I would just like to end by asking a show of hands, if anyone would be interested in participating in the new teaching kitchen, which will be opened in March here at Phipps with Leslie Bonsi and Lisa Silberg, my friends, who run an incredible nutritional gamut for heart-healthy eating. And we would do it in the context of studying and talking about omega-3s. There's a trial that's ongoing. The enrollment is done. It's really to try to answer once and for all whether reducing triglycerides with omega-3 fatty acids can actually improve hard clinical endpoints, cardiovascular death or all-cause mortality. The enrollment is finished. We're just waiting for the event summaries to go over 1,600. We're almost there, not quite. So with that, I will leave you. Whoops. And if there are any questions, I think we'll wait till the end, because I would like to have time at the end to walk around in the magnificent Phipps, especially tropical forest that is kept open for us for this evening. Thank you.